and welcome to this episode of Scrutiny, my weekly investigation and a research-based show where I rely on a lot of data, past documents to bring you a perspective either on important burning issues or on forgotten issues that need to be revived and looked into. Today's discussion is about an announcement made by the government barely 2 days ago that they're going to convert or transform rather the Goa Medical College into a 5-star facility. And that is what we are discussing today. 500 crores have been allocated by the benevolent Chief Minister of Goa, Dr. Pramod Sawant, to augmenting the Goa Medical College. And of course, a lot of money is going to be spent. We will look into that as well. But we are asking a larger question. Do we need a 5-star GMC or do we need a 5-star effective health system in Goa? And that is the fundamental question, and we'll go into that. This is Inc. Goa and I'm Shujoy Gupta. The Goa Medical College, as I said, should surely be strengthened. There can be no argument about that. GMC is Goa's primary tertiary hospital. Its medical college is most important referral institution. And for thousands of Goans, the final destination when treatment is unavailable anywhere else in the state. But a 5-star GMC cannot mean cosmetic excellence at the top, while institutions below it are unable to provide essential services. That is important. The Goa government has announced that the GMC campus will be transformed, as we said, with underground cabling, improved lighting, landscaping, parking, and other facilities. The work is expected to be completed through the Goa State Infrastructure Development Corporation by March 2027. Do remember, this is election year. The Chief Minister has also announced an additional 500 crores for strengthening GMC and its allied infrastructure. So now let us look specifically into this. Where will the money go for this 500 crore transformation? 200 crores has been allocated to the college block. So this is academic infrastructure. 106 crores for the resident doctors hostel. That is accommodation, which could support recruitment and retention of doctors. Fair enough. Boys hostel, 90 crores. Again, this can be counted as student infrastructure. IPHP facility, that is the Institute of Psychiatric Care, where that treatment is given to people who need treatment, who are mentally disadvantaged. Now 100 crores has been allocated for a daycare center there. So it's a tertiary hospital mental health facility. Fair enough. And the other campus plans are, as I said, underground cabling, fast link between the GMC and the super specialty block so that you could connect quickly, and a proposed online OPD for consultations and prescription renewals. The central question is, how much of this investment will directly improve clinical services and how much is it for academic, hostel and campus infra? Now, there is nothing inherently wrong in improving hostels, lecture halls, parking, physical appearance of the GMC. The 40 crore lecture hall complex will surely strengthen medical education. Better accommodation will help doctors. Direct connection between the main hospital and the super specialty block is necessary because currently patients have to be shifted in ambulances between the two campuses. Fair enough. Proposed online OPD also could help patients, especially from Kankon, Perne and other distant areas, who now travel to Bamboli mainly to show reports and renew prescriptions. But the test of the 500 crore expenditure cannot be whether the GMC looks like a 5-star campus. It must be whether GMC becomes more efficient. And at the same time, whether the entire public healthcare system beneath the GMC is strengthened. Critical. It cannot have a 5-star GMC, a 5-star island, surrounded by an under-equipped referral system. And the most significant indicator of this problem is that the number of patients sent to the GMC from hospitals that should be capable of handling a much larger proportion of Goa's medical emergencies. Assembly linked information that we have procured in March 2026 showed 11,738 patients were referred to GMC in 2025 from the 2 district hospitals and the Ponda Sub-District Hospital. Let us look at this graphic on your screens. From the South Goa District Hospital, there were 4656 referrals. That is 39.7% of the share of the referrals. North Goa District Hospital, 4124 referrals. That is 35.1% of the referrals. Ponda Sub-District Hospital, 2958 patients were referred, roughly 25.2% of the referrals, which takes you to the total of 11,738 patients who were referred. This approximately corresponds to 32 patients referred to the GMC every day only from these 3 hospitals. Now, a referral is not automatically an evidence of failure. GMC is a tertiary hospital. Complicated cases come there involving neurosurgery, advanced cardiology, oncology, nephrology, and other super specialties. That is understandable. The real question is not why each patient had to be referred, but was the transfer clinically necessary because only GMC could provide that tertiary treatment, or was the patient sent to Bamboli because a specialist was not available lower down, or whether an ICU was not functioning, whether a CT scanner was broken, or emergency dialysis could not be provided, or an operating theatre was not staffed, or essential diagnostic facilities were absent. This is the question that we are asking. In a recent video that we did called "Where is the Government in Netravali?" we showed you the non-functioning, the closed sub-health center. And that is a story that gets repeated again and again. Now, the reasons officially disclosed for these referrals show that a substantial part of the pressure on GMC originates in missing capacity elsewhere. Now let us look at this graphic. Why are serious patients sent to GMC? Now let us look at this is data which has been got from different sources, including the CAG report. Why are patients sent from the North Goa District Hospital? The most normal causes: no ICCU, no CCU, no emergency dialysis, major specialist shortages, CT scanner defunct since 2024 March, no MRI or advanced CT facilities, accident, cardiac or stroke cases sent to GMC. Now, let us look at this cutoff period by the end of 2025 or beginning of 2026 and leave it there. If improvements have happened later, the government can tell us, yes, improvements have happened, we'll be very happy. Why are patients sent from the South Goa District Hospital? Cardiology, neurology and nephrology gaps, not there, or gaps. Limited dialysis and renal emergency care. 3. No early coronary angiography. 4. Advanced ICU, neonatal and pediatric care gaps, South Goa Hospital. Fifth, cardiac care, stroke, snake bite, poisoning and renal cases are also referred to GMC from South Goa. Now, the South Goa hospital at full capacity has 500 beds. It has 1,500 to 1,700 OPD patients daily. It has 150 casualty patients daily, but it has continuing staff shortages. Then also the level 2 trauma unit is only a building. It does not have staff or equipment. These are not minor deficiencies. A patient suffering a brain hemorrhage may require an immediate CT scan, an examination by a neurosurgeon. An unstable cardiac patient may require immediate attention, may require a cardiologist, a coronary angiography, and urgent intervention. A patient suffering from acute renal failure may need emergency dialysis. A child may require intensive care and ventilation. A neurotoxic snake bite patient may need ventilator support. We all know what happened to Congress leader Ketan Bhatikar in Ponda. In all these conditions, time is a part of the treatment. If the necessary facility is unavailable at a district hospital, the patient must first be assessed, stabilized, and placed in an ambulance and transported to Bambule. The pressure created by this weakness is then transferred to GMC's casualty wards, diagnostic departments, intensive care and other specialists. So therefore, the government's 5-star ambition must begin by recognizing GMC's overcrowding. And it is not only GMC's problem. It is also the result of what the rest of the system cannot provide. The most comprehensive official examination of that system is the Comptroller and Auditor General's performance audit on public health infrastructure and management of health services in Goa. This is a very important document. Unfortunately, neither the media nor opposition parties read CAG reports in the manner that they should. And the government, of course, hardly takes any action on it. This report was tabled in the Assembly on August 7th, 2024. We admit that this CAG report is 2 years old as far as tabling is concerned and covered a period from 2016-17 to 2021-22. Before the government jumps and says you are giving us data of 2022, that is the last available data that is available, and that is the data that we can provide. If there has been a phenomenal improvement from 22 to 26 on all the issues that I'm going to list out right now, we request the government to please give us an update on each of these. And if there is no update and the system is as bad as what the CAG report has stated, then please admit to the same as well. Now let's go to the next graphic. This is the CAG report and I'm going piece by piece. This is again audit period 2016-17 to 2021-22 report tabled in August 2024 in the State Assembly. What does it say? First thing, Goa's healthcare gaps. Only 19.94, close to 20%, of health allocation of Goa's budget went to primary care. Merely 20%, less than 20%, against the 66% requirement by the National Health Policy Framework. 66% of your budget health budget should go to primary care. Only 19.94% goes as far as Goa is concerned. Goa had only 6 of the 12 required community health centers, a 50% shortfall. Only 28 of the 48 required PHCs or UHCs were there. You need a minimum of 48 primary health centers or urban health centers, PHCs and UHCs. Goa has only 28 of 48, a 42% shortfall. Goa has only 220 of the required 291 sub-centers, a 24.4% shortfall. And just 26 to 41% of the capital funds for health infrastructure was utilized during that period. The CAG recorded long delays in GMC's tertiary, cancer center and trauma care upgrade. If things have happened after that, again, we are willing to accept that information. The funding or the finding on primary healthcare is central to this entire debate. 19.94 of Goa's primary health allocation recorded to primary healthcare compared to a 66% envisaged by the National Health Policy is not just shocking, it is alarming, and it tells you that the shine of the 500 crore 5-star package to GMC completely pales into insignificance when you know that only 19% of your budget is spent on primary healthcare. Primary healthcare means the first level of organized medical attention through sub-centers, primary health centers, wellness centers, urban health centers. These institutions are expected to provide preventive health care, maternal care, child health services, treatment for common illnesses, basic diagnostics, management of chronic diseases, and the early recognition and stabilization of emergencies. And let me tell you this, Goa has a fantastic dedicated cadre of doctors working in our rural areas and smaller places. They are just not given the facilities. The fact that primary healthcare still works in most places is because of the dedication of the doctors who perform in spite of the system and not because of the system. Now, secondary healthcare is provided through community health centers, sub-district hospitals and district hospitals. This level should offer specialist consultations, inpatient treatment, surgery, obstetrics, anesthesia facilities, orthopedic, emergency services, diagnostics, intensive care, trauma care, and so on and so forth. GMC represents only tertiary care, which means the advanced super specialty end of the system. Therefore, the public discussion cannot be reduced to villages versus GMC. The real question is whether the three tiers function as one connected system. The CAG found deficiencies or vacancies, among doctors, nurses and paramedics across both primary and secondary healthcare. Now let us look at the staffing gaps that I was just referring to. As of March 31st, 2022, North Goa the primary care facilities had 48 of 274 posts that were vacant. The South Goa primary care had 81 of 452 posts vacant. The North Goa secondary care had 114 of 563 posts vacant. The South Goa secondary care had 145 of 773 posts vacant. This shortage was worsened. Assembly data reported in March-April 2026 said 4,489 sanctioned health department posts. Out of the 4,489 sanctioned health department posts, only 3,208 personnel were in position. 1,281 posts were vacant. Overall vacancy 28.5%. Now this includes vacancies amongst doctors, nurses and paramedics. Of course, one may say a lot of people were appointed on contract and so on and so forth. I'm not getting into the contract issue right now. That is another very big universe. The 2022 primary figures cover PHCs, UHCs, and the secondary figures cover CHCs, sub-district hospitals and district hospitals. Now, let us look at what else the CAG found. They found that the DHS had hired doctors, nurses and paramedics on contract beyond the number of regular vacancies. In certain categories where essential services were not available, CAG findings that you have recruited people on contract beyond the required vacancies, leaving the specialist services vacancies still unavailable. The problem is not in the number of people who've been unemployed, but it is about how sanctioned posts are designed and where personnel are deployed, whether specialists are available, and whether every institution has a complete term required to deliver a service. A lot of people, especially the opposition and others, have called this the Valpoization of the health service, meaning massive recruitments from Valpoi of non-specialist categories, leaving the specialist categories vacant. This has been the opposition allegation for a very, very long time. A surgeon without an anesthetist cannot compete. A ICU machine without trained staff does not create an operational ICU. An ultrasound machine without a radiologist does not provide a diagnostic service. Now I'll look into staff shortages in areas in remote parts of Goa. Plus I'll get to GMC also. Pernem and Kankon CHCs. I'm just giving some examples. I can't get into the entire state. Let's look at Perne and Kankona on two opposite ends. No surgeons or anesthetists in the respective PHCs. Operating theatres non-functional. I'm talking of Perne and Kankon CHCs, community health centers. Ponda and Chikali Sub-District Hospital. No surgeon, Ponda and Chikali. No surgeon or anesthetist, both. Surgeries and C-sections referred to district hospitals or GMC. CHC cannot do it because no surgeon, no anesthetist. North Goa District Hospital ICU equipment unavailable. Sorry, I'll correct that. North Goa District Hospital ICU equipment available, but ICU non-functional due to lack of trained staff. GMC 51% shortfall of doctors and medical officers. GMC's super specialties vacancies range from 18.18% to 81.25% in GMC super specialties. Source: CAG Goa Health Infrastructure Audit 2024. If the government wants to deny, tell us what documentation have they done, what correspondence have they done with CAG, either denying these and giving them the correct figures if it is wrong, or taking corrective action. CAG also examined whether the existing institutions were providing the services prescribed for them. It found gaps in essential inpatient services in both district hospitals, all the CHCs, and the test-checked sub-district hospital. And this is the graphic that is coming up now. CAG essential hospital services missing. Perne CHC, 4 of the 5 prescribed OPD services unavailable. Kankon CHC, 3 prescribed specialist OPD services unavailable. No newborn stabilization units in Perne, Kankon or Ponda, Chikali. No ultrasound services at 2 tested CHCs. Reason: shortage of radiologists and other medical staff. Source: CAG Goa Health Infrastructure Audit Report 2024. I do not say anything without sourcing it. This is all available public information in CAG. This brings us to the particular problem of the cardiac and trauma emergencies at Goa's peripheral health facilities, because cardiac and trauma are 2 of the most important challenges that everybody has to deal with on a daily basis. Now, a PHC is not expected to perform angioplasty, neurosurgery or any trauma surgery, we admit that. But it must be capable of recognizing an emergency immediately, performing an ECG, administering protocol first line of treatment, providing oxygen, using a stabilizing patient, and arranging a safe transfer. At designated adequately equipped centers, trained doctors should be able to provide thrombolysis where clinically indicated. Now, Goa has instituted this hub and spoke system called the STEMI program and cardiac ambulances. We admit that. It's an important initiative and must be acknowledged. The program is intended to connect peripheral centers with cardiac expertise and reduce delays in diagnosing and treating cardiac attacks. Very noble mission. But the existence of the program does not answer whether every identified center has doctors, nurses, functioning ECG machines, medicines, oxygen, teleinterpretation, and an ambulance pathway available at all hours. The operational data should tell us how many ECGs were conducted at each peripheral center, how quickly they were interpreted, how many patients received thrombolysis, and how long transfers took, and what the outcomes were. Next, medicines were another area of concern in the CAG report. Look at this next graphic. CAG, massive medicine shortages. In the North Goa District Hospital, 351 of the 530 items were unavailable during this period of inspection. 66% unavailable. Ponda and Chikali, 334 of the 441 items unavailable. 76%. Perne CHC, 77 of the 176 items unavailable. Concon, 76 of the 176 items unavailable. Free medicines were not provided. This is the report of the CAG. Prescription checks found 10% to 83% non-provision of free medicines across sampled DHS institutions and GMC. Why are free medicines not provided? Again, source CAG Goa Health Infrastructure Report 2024, Audit 2024. Now we look at, there's one more point. In prescription samples, as we said, this non-provision of medicines, free medicines, is something that is extremely serious, because this points to something else. Where are the free medicines going? Are they being pushed back into the market and money being made by unscrupulous people? This is a very important indicator when you know that free medicines are not reaching the hospitals. Now we look at some damning observations made by the CAG. No comprehensive procurement policy for medicines. No centralized procurement body. Delays in tenders for drugs, consumables, and also equipment. Inadequate safeguards for testing medicine batches. Deficient medicine storage at some health facilities. Source CAG Goa Health Infrastructure Audit 2024. The CAG also recorded serious gaps in medical equipment. Next graphic coming up. 494 equipment types required across 8 departments. This is the 494 equipment types are required across the 8 major departments of GMC. Only 315 are available in full quantity. 76 are available but in insufficient numbers. 103 equipment types of equipment completely unavailable. North Goa District Hospital, only 45.83% of the required operation theatre equipment is available. Imagine, 45.83 only equipment that is required, 45.83% of the equipment required for OTs available. Endoscopy equipment availability, just 28.5% of the equipment required for endoscopy is available at the North Goa District Hospital. The Chikali Sub-Hospital, again, imaging equipment 40%, laboratory, these are shortages, imaging equipment 40%, lab equipment 42.4%, operation theatre equipment 39.1%, ENT equipment only this is the available figure, imaging equipment 40, lab equipment 42.2, OT equipment 39.13, ENT 13.64, and endoscopy equipment 0%. 0% available. So therefore, the CAB found that procuring equipment took between 9 months and more than 2 years from tendering to installation. This is the time it took to even installing an equipment that's necessary. Operating microscope, described as urgently needed, took 1 year and 7 months to procure and install. They've just given a case study. And operating microscope needed urgently took 1 year and 7 months to procure and install. These figures explain why the equipment availability cannot be measured only by counting the machines purchased. The government must ensure and measure whether such equipment is installed, staffed, maintained when a patient needs it, not 1 year and a few months later. The state can point to genuine improvements after the audit period. I'm sure they will try to do so. The South Goa District Hospital ICU became operational in May 2024. A A-level trauma unit has been under construction. PHC upgrades have been announced for Sange, Kurtori, Kandoli, Margaon, Kunkoli, Bhetki, Markai and Purvuri. Goa has cardiac ambulances and a STEMI network, STEMI network. The government has announced 270 new healthcare professional posts. All this has happened after the edit. But what must be verified from these claims? PHC upgrade. Next graphic. Which services, equipment and staff are operational and for how many hours? Cardiac ambulance STEMI network. Give us the center-wise data on the ECGs, thrombolysis, transfers and outcomes. 270 new professional posts. These are all claims by the government. New posts or existing vacancies? Please clarify. Permanent or contractual? Please clarify. Deployed where? Please clarify. From where? Please clarify. South Goa Trauma Unit. When will construction, equipment installation and specialist staffing be completed? Do answer. Online OPD. What supports the claim that GMC's rush will fall by 50%? Because the CMS claimed that the rush will fall by 50%. How will patients without digital access this online OPD? When you don't have internet connections in most remote places and they are the ones who need it in Kankan and Penne, how will they get onto this online OPD? Please answer. Therefore, these improvements, we are not dismissing them. They are good, they are well intentioned, but announcement must be measured against operational results. And that is what most people do not do. They simply report what the government has announced. The issue is not GMC versus Goa's villages. It's whether Goa can build one functioning healthcare system. Therefore, peripheral hospitals need a capable GMC for advanced technology, but a 5-star test must therefore be clinical and not cosmetic, and a 5-star test should also pass the total health system test and not just how good GMC will look. The test must be whether a villager suffering from chest pain receives ECG within minutes, whether a heart attack is identified without a delay, whether an accident victim can be stabilized close to the crash site, whether an operating theatre has a surgeon and an anesthetist and a nursing team, whether an ICU machine has a trained operator, whether a CT scanner works when a stroke patient arrives, whether medicines prescribed at the government hospital are actually available free of cost. GMC needs investment, it needs better patient flow, it needs academic infrastructure, it needs specialists, it needs functioning equipment, it needs efficient online services, it needs humane wards, it needs proper parking, it needs all of this. But it cannot build a 5-star campus at Bamboli while patients across the state continue to be transferred there because essential staff, diagnostics, facilities, intensive care, trauma services and medicines are unavailable closer to their homes. The objective must not be one 5-star campus. It must be a functioning public healthcare system from the village health center to the district hospital and finally to the Goa Medical College. This is all we have today. If the government wants to counter this and give us figures, we'll be happy to accept that challenge. This is Inc. Goa. Keep watching us, keep supporting us.